Hello, my name is Ruben Kenny Briceno. I'm an infectious diseases doctor. I work at the Hospital de Alta Complejidad Virgen de la Puerta in Trujillo, Peru, and also for the Institute for Global Health and the College of Osteopathic Medicine at Michigan State University. Today, we are going to talk about a very sensitive topic, a pan drug resistant infections. These are caused by superbugs. So, for this presentation, I have no conflicts of interest. First of all, we have to talk about bacteria. As you know, infections can be caused by several kinds of pathogens like viruses, fungus, bacteria, parasites. But bacteria are especially important because among all the infections are the ones that causes the major lethality and an important number of deaths are because of the infections caused by bacteria. And we can categorize bacteria in gram negative and gram positive. This is very important because the treatment and the management of patients will be a little bit different depending on this. So, talking a little bit about resistance, it started from the very beginning that we started to use antibiotics. So with the discovery of penicillin, then we um, started to see resistance, and that's how the story began. Gram-negative bacteria's resistance are, like I said, a main concern in healthcare systems. Some colleagues are a little bit fatalist, and they say that the fight is lost. I do not believe so. I think that we can have a space and time to fight back. But some of them say that they are more pessimists, and some of them say that we have lost already the loss against uh, bacteria. But what is it? What is this pan drug resistance? Well, this is a term that among microbiologists and infectious diseases doctors we use to classify the different kinds of resistance that we have. For example, MDR, which stands for multi-drug resistant bacteria, are non-sensitive to at least one agent in three or more antimicrobial categories. Then we have XDR, extreme resistance, non-sensitive to at least one agent in all categories except in two or less. And then we have PDR, so pan drug resistance, non-sensitive to any agents in the antibiotics categories. And what I mean by categories, here's a slide to explain that. Here, these are the different categories that we have for the classification of antimicrobial. We have beta-lactamans, no lactams, we have glycopeptides, tetracyclines, oxazolidinones, macrolides, fluoroquinolones, etc., etc. And here I have a antibiogram. This is what it looks like. That's what comes from the laboratory. Let's say we have a isolation of Klebsiella pneumoniae, and what you are seeing is once in one side we have the antimicrobials, in the other side we have the name of the uh, microbe. Actually, we have two here, Klebsiella pneumoniae and Pseudomonas aeruginosa. And then we have the minimum inhibitory concentration. What does it mean? It means, as you know, that this is a halo formed by the antimicrobial, and that halo allows us to um, know how effective the antimicrobial is in the presence of these bacteria in this culture. So a pan-drug resistant bacteria means that um, this specific microbe is resistant to all the antibiotics listed in this slide. Uh, like I said, from the very beginning, the bacteria started to, um, let's say, develop resistance mechanisms to survive. So that's their goal, to survive. So what they've done, they have developed different mechanisms to do so, like active efflux with pumps, enzymatic inactivations. They have altered the target, they change it, so the molecules of the antimicrobials, once they are in the cell, they cannot recognize, so they cannot be effective. And they also decreased the number of porins that they have, so um, they won't allow antimicrobials to enter their cells. And what is it so important? Because globalization brought us many advantages, but also there is a dark side of globalization. And because of globalization, now everything is closer. And just in a matter of hours, you can be in another continent and you can carry with you several pathogens, several diseases, and also you can um, carry with you bacteria with resistance to other parts of the planet where they previously didn't have it, or with food or animals you can send to other countries, other continents, this kind of bacteria. Here in this slide we have a a good example of a kind of resistance which is a very dangerous resistance, the MCR genes, which is Mobius colistin resistant genes. And why is it so important? Because colistin is one of the last resources that we have to fight bacteria. If we lose colistin, then that means that there is very little we can do to save that person. In this slide, in this study showing us, like for example, in the graphic A, the proportion of clinical isolations, that means in humans, of these genes, MCR genes for colistins, and as you can see, there is a almost a fourth of the proportion clinical, and then out of this universe of isolations, there is a huge amount of isolations found in animals, and among all the different kinds of MCR, the most prevalent is the MCR1. On the other side of the slide, you can see where you can find these isolations. If it's in the environment, the most prevalent, it's in the food, animals, etc. And why is so important? Why do we care about resistance? First, because it threats our very existence. That means that if this is not controlled properly, there will be the time when you get sick with an infection and there will be no cure for this. The infection will spread to your body, will spread to your bloodstream, and you will die of sepsis. So we will go back to the beginning where there was no infections at all, there was no antimicrobials at all, and most of the times to have an infection, that means a sentence of death. that will happen. And that's exactly what is going on right now with the PDRs, with pan drug resistance. Once is declared when we diagnose an infection with a antibiotic, with a pathogen that is pan drug resistant. Like I said, we try some combinations of antibiotics, but basically there is nothing else we can do for that person. Uh, the other, the other, the other important thing to talk about is economics. How much does it cost to treat a person with a PDR pathogen? It costs a lot of money. First, because we have to isolate the person. We have to assign a specific, well-trained personnel to treat that patient. The area must be isolated, and the drugs that we use are very, very expensive. And if this pathogen is not contained properly, it will affect other patients, and the burden will increase, and the mortality will go very high. And not only that, this is economics. It's very important because countries spend a lot of money on these kind of bacteria. But what about the person? Once a person is infected with these pan-drug resistance bacteria, the quality of life will be diminished. If they manage to survive, then they, in many times, they will be colonized by these bacteria, and meaning that they may have a latent infection for the rest of their lives. And last but not least is the timing. Timing, because in the way that these infections are spreading around the globe, and the time that it takes us to discover or to develop new antimicrobials is disproportionate. This is spreading very fast, and very soon we will have a pandemic of these superbugs among us. Here in this slide, you can see the deaths attributable to antimicrobial resistance by 2050 will be 10 million people. 10 million people will die out of this kind of bacteria. Talking about GDP, but US trillions, it will be 100.2 trillion US dollars that countries will spend trying to fight back, and this will be the impact of antimicrobial resistance, economically speaking. Like I said, these superbugs, they do not respect borders. They can be in several countries very fast, and they can be spread rapidly. And what are the bacteria that we are talking about? Specifically, we are talking about nosocomial bacteria, which means the bacteria that we have in the hospitals, and community pathogens, meaning that among our communities we have some pathogens circulating that can cause resistance infections. The most important that we have there are Enterococcus spp, Klebsiella pneumoniae, Acinetobacter spp, Pseudomonas aeruginosa, Staphylococcus aureus, E. coli, Enterobacteria, etc. That's in the clinical settings and the hospitals. And then the pathogens, we have Salmonella, Shigella, E. coli, gonorrhea, Streptococcus pneumoniae, Haemophilus influenza, and Campylobacter. We have categorized these bacteria and we call them escape bacteria. Um, they are responsible of most of the um, hospital infections, and they are also, like their name say, they are able to escape the action of antimicrobials. The ones that we're talking about are Enterococcus, Staphylococcus, Klebsiella, Acinetobacter, Pseudomonas, and Enterobacter. And I will add Clostridium difficile as well to that one. So here are some mechanisms that bacteria uses for to escape the action of the antimicrobials. Like I said, there's a categorization of gram-negative and gram-positive bacteria, right? So they have developed many of them with the in the matter of we have started. This is on the 1920s is that we discover penicillins, and then by the time right now 100 years later, pretty much all the antimicrobials that we have created, all of them are expressing, they are showing resistance. Bacteria are very clever, and they have developed different mechanisms to get rid of the bacteria that we have uh, created so far. So human HDR and PDR in the Americas, the most concerning to us are the Enterobacterias, Acinetobacter, and Pseudomonas aeruginosa. And these are a priority pathogens for resistance and for the creation of new antibiotics by the WHO, the World Health Organizations, in the Pan American Health Organizations. Acinetobacter, which is critical because it's very related to the ICU rooms, as well as Pseudomonas enterobacterias. And among these, the carbapenem resistant, third generation cephalosporin resistance, we are talking about ESBLs, uh, bacteria. And then in prior two, which is high, we have Enterococcus faecium, Staphylococcus aureus, Helicobacter pylori, a Campylobacter, Salmonella, Neisseria. And in prior three, medium, we have Streptococcus pneumoniae, Haemophilus influenza, and Shigella. Here, this is a study made by published in Lancet, talking about the same thing. Acinetobacter baumannii is among the one is the first one that we is causing us concerns. And why Acinetobacter? Because they can express from the very beginning of the infection, they can express resistance to all of the antimicrobials that we have available right now. The mortality is very high. Mortality is very high once you acquire these bacteria. Pseudomonas aeruginosa is one of the most problematic pathogens that we have. If you get infected by Pseudomonas, then Pseudomonas can infect also the different machines that are in contact with Pseudomonas, and they can live even on the sinks of the hospitals. They can live in water where you wash your hands. So, what I'm trying to say here is that it is very important to know how to treat these bacteria and what we can do to fight back. Well, some ideas uh, of these are, for example, in low or middle income countries. Uh, I would say that the order that it reflects here is not necessarily how it should be, like 1, 2, 3, 4, 5, 6, 7. I think that this must be done at the same time. Like, for example, let's say let's start with educational programs for prescribers and users. In my country, in Peru, if you have an infection, even if you have a cold, or if you scratch with your skin with something, you are free to go to the drugstore, any street drugstore, any pharmacy, and you can buy one of the most potent antibiotic that you can think of. Let's say if you have a wound in your skin, even if it's just a scratch, you can buy uh, meropenem to treat that uh, that scratch if you want. If you have a cold, same thing. You just go to the pharmacy, you ask for the antibiotic, and they will send it. They will sell it to you. No prescriptions. They won't ask you for your ID. There is no control of that. So I think that that must be regulated. Um, I don't know how do you manage that in your countries, if it's the same happens in the same in your countries, but in Peru that's what happens, and that's one of the causes why we cannot control um, our resistance in our country. Um, the other one is that our personnel is not well trained on prescribing antibiotics. We have many cases where antibiotics are prescribed to treat viral infections. So that's something that you should not do. Or if it's a very light or even moderate infection, they treat it with the most potent, powerful antibiotic available. And this is also because the parents they have in their mind setting that the stronger the antibiotic, the fastest their patient will heal, and the better the doctor who prescribed. So if you prescribe very expensive medicine and also this drug, of course, is gonna work for if it's just a light infection. Of course, it's gonna work in a way. Uh, then uh, your patients will respect you more. Why? I don't know why, but it's very common that you receive compliments or someone receive compliments because of they prescribe very expensive antimicrobials, which is wrong and that should be done. And then we have some other uh, ideas like implementation of antimicrobial stewardship programs in the hospital. Like, for example, in my hospital, we have implemented one of antimicrobial stewardship, where if you want to prescribe any uh, any antimicrobial, let's say carbapenems or oxazolidinones, then that must be evaluated by the infectious diseases doctor, and, and depending on their evaluation, you will get it or not. Um, and this is something I would like to talk the development of rapid and affordable diagnostic technology. That's what we are trying to do with Dr. Banji and a group of researchers around the globe. Um, there is a very uh, important component on this change of treating a patient in a hospital that begins with the diagnosis, a proper diagnosis. If you diagnose properly um, a pathogen that causes a certain infections in that patient, and you give the proper antibiotic, the chances of survival will be increased by 70%, which is huge when you are talking about survival in patients. But what we have now, what we have available right now, does not reflect what should be, because what we have available right now takes several days until the physician will know for sure what is the pathogen, the correct pathogen that is causing the disease, and if you are using a proper antibiotic or not. So, if we will have rapid, affordable diagnostic technologies that could allow us to know in real time what's the pathogen and what's the characterization in terms of resistance, then we will actually be saving life by a lot, and meaning that we will have a powerful tool to fight back antimicrobial resistance. So, this is what we were talking about. Like I said, from the very beginning, we were fighting infections by pathogens with what we had available. This is a pipeline of antimicrobials, and right now we are trying to develop new technologies for new antimicrobials, because the ones that we have, like I said, we have pan drug resistance anti bacteria that cannot be cured, or are not and our antimicrobials are not effective against those bacteria. So this is a publication by Nature. This is 407 preclinical antibiotic projects for several institutions, which they are trying to develop antimicrobials, different kinds of antimicrobials, like direct acting small molecules, potentiators, repurposed drugs, antibodies and vaccines, immunomodulators, antivirulence approaches, phages, and microbiota. And here we have a slide showing that direct acting antibiotics are the ones that most promising and the ones that many investigators are working on. Where how advanced are we um, on these studies? Well, here we have like 103 are hit to lead, 81 are lead to optimizations, and 81 in North America, Europe, and other countries are studies enabling clinical trials, or they are trying to implement their applications. So, like I said, I last but not least thought about what we have seen and what we have presented is that infections by gram-negative bacteria are the ones that are causing most of the troubles than infections by gram-positive bacteria. I think that we still have more room and more resources to fight and infections by gram-positive bacteria than gram-negative bacteria. But we definitely need a new approach on this, because otherwise we will have many troubles in the years to come. Thank you very much.